Hi, this is Allison, and here is a discussion of my theory on counseling. So, real quick, I'm just going to touch on Maslow's hierarchy of needs. So, when a patient is in the hospital and I'm taking care of them as a registered nurse, the patient is pretty much at the mercy of their body and the environment and everything going on around them. My job is to help meet those basic needs of food, clothing, and shelter, um, as well as provide safety and security and making sure that the family stays involved to promote sense of belonging and to help the patient empower themselves and enforce their feelings of self-esteem and accomplishment. Um, we I take care of a lot of people who come in with congestive heart failure where they have too much fluid on their bodies for probably for a heart reason most likely. Um, and we help patients increase their self-esteem and feeling accomplished by involving them in patient-centered care where they are a partner in their own healthcare. They become involved in everything that we do, and if they have questions, they ask questions so they can continue to feel accomplished on the outpatient setting by taking care of themselves. Self-actualization I'll get to next, but it's pretty difficult to help a patient self-actualize in 8 to 12 hours, let me tell you. So Carl Rogers' client-centered therapy builds on Maslow in that humans have a tendency to strive toward growth and self-actualization. The 6 factors that Rogers' theory suggests focus on the therapist, the client, and the relationship between the two. Obviously, there must be a relationship between the two, and then the client will then go on to identify discrepancies between current actions and the goals that they want to make. Meanwhile, the therapist must be genuine, self-aware, and congruent, as well as true to him or herself. The client should be accepted by the therapist without judgment. We call this unconditional positive regard. And the therapist must demonstrate empathy. And the client can tell when the therapist is not being genuine, non-judgmental, or empathetic, and that can lead to further discrepancy in the client. So important to use verbal and nonverbal cues when speaking to the client. So motivational interviewing advances client-centered therapy. Unlike client-centered therapy, MI has a goal, and the goal is to eliminate or minimize ambivalence. So we do this through client-counselor collaboration, and as well as the counselor respecting the client's autonomy, ability to make decisions for themselves. But at the same time, the counselor knows how to evoke change talk, so the client makes his or her own arguments to change. So the spirit of MI is closely related to client-centered therapy as well. The unconditional positive regard and non-judgmental attitude leads to resisting that writing reflex that Bauer and Liu discuss. The writing reflex can lead to confrontation and a weakened counselor-client relationship. The counselor also must understand motivations from the client's perspective. Here, the counselor can identify barriers to change and evoke change talk. Showing empathy and using reflection, affirmation, and summarizing techniques, the counselor can help the client feel empowered to resolve his or her ambivalence. So my theory kind of involves a little bit of everything. The client or patient is always the priority. Counselor self-care is very important as well, but when you're with the client, the goal is to have the client figure out how to reach their goals based on their situation. The counselor or medical professional should also be genuine and and have already identified feelings within themselves that could impede the client's progress. For example, identification of your feelings towards groups of people. So if you do encounter somebody within a group, you've already become aware of your feelings. That way you can maximize competence, keep an open mind, as well as be respectful. Next, the client or patient cannot meet that MI goal of eliminating ambivalence without having fundamental needs be met first. This is kind of where the counselor turns into a social worker. So, for example, somebody who is using a substance, they are not going to necessarily worry about where their next meal is coming from because they're addicted. But on the other hand, somebody who is worried about where their next meal is coming from isn't going to worry about their health status. An example of basic needs being met leading to self-fulfillment would be sober living homes, which provide those basic needs of food, clothing, and shelter, as well as provide a feeling of belongingness, since most people living in those sober homes are, for lack of a better phrase, in the same boat. They are doing it all together. Sober homes also help people find jobs, which can lead to feelings of accomplishment and self-esteem and sustained behavior change. And the last thing I want to mention is that self-actualization process doesn't stop. It's always moving, continuing to grow. When I was a freshman in high school, my band director said that the moment you stop trying to improve yourself is the day that you should roll over and die. I know that sounds a little unprofessional, but his message is very clear in this case. Once I reach a goal, I'm always looking for the next project, the next program, the next class. I'm always looking for ways that I can improve my own practice as a nurse. This degree is a process of self-actualization, and it's not the last one, clearly showing that Carl Rogers was right when he said that people are always moving towards self-actualization. They're always moving in a direction, and it's our role as counselors to help that person find their full potential by putting the patient as a priority, being genuine in our approach, and helping the patient meet those basic needs so they can find their full potential. And last is my references. I hope you enjoyed my theory and discussion, and we're almost done, and I'm sad to see this class end, so I've learned a lot, and thank you so much, Dr. Maya.